I'm going to go first just in case I have to step away, if that's okay with
Sure.
everybody.
Yeah.
Okay.
All right. Okay, let's see here. This is an interesting case. Unfortunately, I don't have biopsy confirmation, but I'm going to see if you guys, let's see, what am I doing here? You see a CT scan, looks like, yes?
Yes.
Okay, so this is an 80-year-old male who I was asked to look at the CT for my thoughts, and I don't know any history. I think he was having some chest pain or something like that. And he's got this very thick rind in his pleural space with this really large, chunky calcification. And to me, this was only one thing I could come up with. I mean, he's no history of malignancy that I know of. That this would be a sarcomatoid mesothelioma, presumably with some osteoid or chondroid differentiation. And there's extension into the mediastinum, into the extrapleural fat right in here. So it's clearly a malignancy. Um, and unfortunately, he's a was going to get his biopsy done somewhere else. But would you guys agree that this is a sarcomatoid meso without really any differential?
Absolutely. Yes.
Yeah. I've seen metastatic sarcomas go to the pleura with matrix, but he has no sarcoma anywhere else. And with the pleural invasion, the rind, I mean the fat mediastinal and extrapleural fat invasion, I couldn't make it anything else. And I believe he did have an asbestos exposure somewhere, documented somewhere in his chart. So, but it's just a really quite exuberant case. I wish I had a radiograph of it, but I didn't, wasn't able to get a hold of one. But you can see there's even this big mass effect right here on the airway. So a
And
sarcoma.
it's growing around the pleural surfaces and in the interlobar fissures, pretty typical of that too.
Yes, exactly. Okay, let me show this one now. So this is another case, and I showed it to some of you earlier this week. This is a 19-year-old woman who carries a history of ulcerative colitis that has been being treated for with medicine and has been doing fine with that. But she's developed progressive shortness of breath, and some of her scans over time, and I only loaded a few up for this webinar, but she has a very interesting finding in her mediastinum. She's got this severe stenosis of her left main pulmonary artery and this soft tissue around it. And you can see it's just very thread-like. But there's a lot of sort of soft tissue in the mediastinum. And then the other area that's abnormal is her right upper lobe pulmonary artery. So, here's the right main coming up, and it's just this thread of contrast going through here and just a little nubbin of the superior segment. Let's see, I've got a newer scan with some thinner cuts. She has, in her older scans, she had sort of progressive narrowing of that left side, and the right side involvement is newer. Um, and she's had a VATS biopsy, a MEAD, and a bronch biopsy, none of which have shown granulomas, malignancy, and they even did IgG4 stains, and none of that was positive. You can see right here in the anterior segment, there's this soft tissue here, but there's just a thread-like pulmonary artery. She had a PET scan done. Not sure exactly what the logic was, but maybe to see if there's a lot of active inflammation, and there's really just a little bit in the just behind the right pulmonary artery and in that right suprahilar region. Let me blow it up. I got the wrong tool here. There we go. Just a little bit of activity right up in here. Not much. And so she's been progressive. Her pulmonary function's getting worse. I don't have it loaded, but her VQ scan shows hardly any perfusion to the left lung. So with this upper lobe on the right now, she's having more problems. And so I think they're going to start her on rituximab to try and see if they can stop this process. But it's just an unusual case in that it's bilateral and there's no calcium. And this is presumably from histo. She doesn't have any other causes, but you just see all this collateral flow. So that, for me, that's a little unusual in fibrosing mediastinitis to have such extensive arterial involvement. But really, I mean, you can see the inferior vein is wide open. The superior vein is a little narrowed, but it's open. So I don't know if anybody had any other thoughts on it, but I think it's a pretty good case for fibrosing mediastinitis.
Jeff, is there fibrosing mediastinitis associated with inflammatory bowel disease?
We looked into that, the pulmonologist who's seeing her and I did, and we could not find anything. UC is associated with fibrosis, small airways disease, and even large airways disease, but that frequently happens many decades later on, often when their bowel disease is quiescent. So I don't know. I mean, I think just two things at the same time. But we also thought about maybe could this be a unusual presentation of Takayasu, which can affect the pulmonary arteries, but you would expect to see a lot more FDG uptake in the arteries on the PET CT. We don't have any, as well as her inflammatory markers should be elevated, which they are not.
The lack of PET activity too makes you wonder if the immunosuppression will help. Is this all just chronic and irreversible?
Yeah, well, I
not
don't
progressing at this point.
Yeah, well, in the older scans, the right upper lobe was okay, so she's starting to lose that right upper lobe, and with her PFTs getting worse, it's worth a shot to stabilize it, because I mean she won't be a transplant candidate almost certainly, and there's really nothing else to do. I mean, they talked about trying to maybe stent the right upper lobe pulmonary artery, but it's small, so someone would have to be able to get a wire across it first. The left may be able to be preserved, but there's not a lot of flow going that way as it is. It's just an unusual case, because I've seen a fair number of cases, and this is only the second time I've seen one without a big chunky rock of calcium.
Well, I think David's question was a very good one. The fact that she has another autoimmune disease and ulcerative colitis.
Absolutely. And is IgG4 disease ever pinch off vessels in the mediastinum?
It could, but when they stained the tissue for IgG4, it was not positive.
So they did look for that.
They looked for IgG4, sarcoid, malignancy. This has been going on for three or so years, and it's just slowly progressing, which is typical of fibrosing mediastinitis. A malignancy would have declared itself, and
So Jeff, did you think that on the PET scan there was activity anteriorly, sort of in the thymic distribution? Was that anything abnormal, or is that normal?
That's normal. That's normal.
Yeah.
Thymic activity there.
How old is she? You said 19. At 19.
19.
Okay, that's okay then. Thank you.
Yeah. Okay, this is another interesting case. This is another young woman. She is 20. Let me see. What are my dates here? 2017. Yeah, let's start. So she presented with a cough, shortness of breath back in the fall, and had this area of consolidation on the left that was presumed to be a community-acquired infection, and she was treated for that. Here's her CT scan. You can see on CT it's actually a bilateral process, and if you look at it, sort of peribronchial, perilobular thickening, so right here, arcading. So a good look for an organizing pneumonia pattern, and goes in the right distribution, peribronchial and all that. But the reason I'm showing it is really her most recent scan. It's just one of the prettiest scans I've seen of atoll signs. You can see them here. So it's an archipelago of atolls. We've got these three right here. And so what's interesting about her is they never really identified a cause. So she was on steroids, and when they tapered her, she recurred with this appearance. So a very different appearance, but still very consistent with an organizing pneumonia. But I thought for the people learning out there that for an atoll sign, these are some of the better ones I've seen, or also sometimes referred to as the reversed halo. So with her, she's going to need steroids, I think, for longer term. And that does happen in about, I think it's about 15% is what the literature says, of people who will relapse after steroid taper. So they often require higher doses for longer periods of time.
Also unusual in such a young person.
Right. You wonder if she has an underlying, if this is a manifestation of connective tissue disease. So she's getting she was referred to us for her, transferred to us and for further evaluation. And I think they're going to do the full workup for all of that fun stuff.
Yeah, hopefully anti-synthetase panel and everything.
Yeah, they'll do it.
Her age.
Yeah, that's why she's coming to us.
That's what I figured.
Yeah. Here's a case that Julie sent me. It's just a real pretty one here of a meandering pulmonary vein. You can see that it was originally thought to be an AVM, and when they went in to attempt to embolize it and injected it, they realized very quickly that it was not an AVM there. So you can see the nice example. And we've seen plenty of these before, but they're always kind of cute. I don't know if I can manipulate the images as much, but you can see it. It comes. This one kind of left upper lobe goes into the mediastinum almost, or right up against it, and then branches back out, and then wanders and finds its way to the inferior vein. And then there's probably a little second one right here, too. So I think it's actually two meandering veins. This guy out in sort of the lingular area.
When I see these, there's no left superior pulmonary venous ostia, so it goes into the hilum where it should then drain into the left atrium, and then it doesn't exist. I think there's some sort of either intrauterine or some sort of something happens to that ostium, and then it finds another way to drain and basically goes back out in the lung.
Do you think it actually does enter the mediastinum and then just turns around and goes back?
Yeah, I think so. I think it's going to where it should be going to an ostium, and then just never something happened with that development, and it has to find another way out.
Cool.
And I've seen that in about half. What'd you say, Travis?
I was going to say, a few years ago, Sushil showed a case of a patient that had AFib ablation and had a stenosis of one of their veins, and then on a subsequent study had developed a meandering pulmonary vein.
Oh,
so
really?
I agree. It's some sort of occlusion, whether it be developmental or in his case, they weren't this large, but they were clearly meandering veins that had developed after the post-op occlusion.
That's neat.
Yeah. So I think you can see the other one right here too, but it's a really big one. Yeah. So it'd be about the size of the superior vein. Well, that's cool. I didn't think about that, but that makes sense.
But Jeff, this one does not connect. This doesn't connect a superior pulmonary vein to an inferior pulmonary vein. It's not a loop between those two. It's not actually connecting all the way back to the left atrium from that anterior thing that looks like an anterior pulmonary vein, right? It doesn't quite make it.
Right. It just goes all the way back down to here.
Which is the left inferior pulmonary vein.
Yeah.
So I think it's
okay.
Yeah.
I got to take a phone call, so maybe one of you, I can switch over one of you guys.
I got some cases if you want me to show. Oh, get that out of the way. Okay, share. So one of them is just a couple of them are just interesting cases. One is actually more of a kind of a little bit of a consult to see what you guys think. So this is a patient who came in with a mediastinal mass, had a known diagnosis, but the interesting thing was she got a PE study, and I think you can always get fooled into. I think most people, if you were looking at this, would notice that there's some sort of abnormal connection with the aorta here. But if you're quickly perusing at it, you might just think it's some sort of cardiophrenic angle, potentially even a bilobed anterior mediastinal mass. You can see that the edges are calcified, that it's actually compressing the RA and RV. And like to show as a residents always say, oh, just put a needle in and biopsy it. And they fortunately got this is an outside study, they got an arterial image after the initial study, so someone made the correct diagnosis, and you can see that this in fact is a large saphenous graft aneurysm. Now you wonder, we were debating like at what point can you get a saphenous vein graft pseudoaneurysm outside of the anastomosis? And I always call these aneurysms, but there were a couple areas where so here you can see it coming down. Here's the connection with the rest of the bypass graft aneurysm, which was still surprisingly patent. But then there are these other areas where you had contrast streaking out. I still think it's a contained aneurysm, but these usually occur 15, 20 years after surgery. Patients are often asymptomatic. Sometimes they do present with cardiovascular symptoms, but there is, if they're untreated, a high mortality, although there's probably a lot of people out there in the world walking around with these, just don't know about it. But this was an incidental finding. Patient just had a cough and had the finding on this chest x-ray that led to everything else. So that's a nice bypass graft aneurysm.
Yeah, the ACR case in point on Monday was a bypass graft aneurysm. Yours is more impressive. But the one thing I took exception to one of their questions because they say that the chest radiograph is not specific for it. But I would argue
it's actually so. Yeah, and when you look at them, I agree. When you look at this radiograph, especially the ones I've had ones that are saphenous to obtuse marginals that sit right here. You can see the adjacent clips. It's clearly mediastinal, has that very smooth contour, like this has a smooth contour. I mean, I think here you could say, okay, the patient's had a bypass. It's in the differential diagnosis as is other cardiophrenic angle masses. But there's some cases where you look at it and you're like, that's a bypass graft aneurysm. It's
right, exactly. Right. Especially if you have a prior radiograph to compare to that shows the slow growth over time.
Yeah.
We've had a few where over the course of years you see it slowly enlarge, but I mean, it's certainly something to include, like you said, when you have a prior median sternotomy.
Yes, especially, exactly. Here's a case that was interesting because people here got fooled by this because of the phase of contrast. And this is interesting, I have to say. So this was a patient who came in, I can't remember the exact reason, had a contrast enhanced scan, and you can see that there's this very classic subcrinal mass. It's got very smooth edges. It's well defined. When I say smooth, I should say deformable edges. It's kind of deforming to the contours of the mediastinum. Unlike that last study where I showed that aneurysm that was displacing the heart and other mediastinal structures, this is kind of conforming to the underlying mediastinal structures. And this was, I still think it's a pretty classic diagnosis, even though it's high density, but this was called something potentially, I don't know, something, and the patient underwent a PET, and you can see here on the PET, on the non-contrast scan, that this is extremely high density, and that there's this layering contrast level in this. Not contrast, just this layering milk of calcium level in it. And it was also quite as, where's the PET images? I'll have to include the PET images, I think. Oh, here they are. And as you can imagine on the PET there, it's just an area of no uptake. And this is just an extremely high density bronchogenic cyst with extensive, I think I maybe seen one that's almost this high density. I don't think I've seen one this high density with the layering milk of calcium level. But I think on the contrast scan, because the contrast attenuation in the vasculature was similar to the adjacent cyst, that there was some confusion about the diagnosis. But it's a classic location, and it's a kind of a classic appearance. If you made this fluid attenuation or low density, I think most of us would make that diagnosis. Have other people seen ones this high density? I think it's a little odd.
No, I don't think I've seen one with
no, that's the highest.
Calcium. That's really neat.
Yeah, because I mean, it was right on the PET. So yeah, I mean, again, you can understand because it is really high density. You can definitely understand why the confusion was there. But on the non-contrast, really pretty how it comes out. So yeah, just an interesting one. I don't think I've seen one that high density before. Oh, this is a case, I don't know what this is. This is more of a consult case. I should have sent it to you guys as a consult case. So this is a patient who is a smoker, but has this, and this has been there forever. And she's young. She's in her 40s. No doubt she's a heavy smoker. But this is all the right middle lobe, this massively hyperinflated. So here's the right lower lobe down here. Here's the right upper lobe up here. And then there's just this massive thing that's all right middle lobe. What do you guys think? Do you think that this is somehow all, I was raising the aspect of some sort of congenital lobar emphysema, although I know some of you guys have shown cases in older patients. I just haven't seen one before. Do you think it's all just really bad pain lobular emphysema from some other cause, or do you think it's smoking, or what do you think?
I like your first thought, Seth, because I think middle lobe is one of the more common places, and the fact it's an entire lobe and it's the only lobe really, that would explain it.
Yeah, because I have studies going back on her for years. This is, I think, a study like with less severe emphysema, where the right upper lobe is not collapsed. And then this thing has just been growing and getting bigger. And I don't know if this is probably, I think, a CT from about 8 or 9 years before, 10 years before. Do they usually continue to progress with increasing compression of the surrounding lung? I just don't know.
So Seth, how big are the vessels going to these lungs? Can we look at a soft tissue window and see if
Sure.
there's a full size of pulmonary arteries and things?
Yeah. So this is the most recent case. And so the vessels to the right middle lobe are attenuated, to say the least. I mean, here's medial segment, here's lateral segment, and these big guys are just basically going into that completely consolidated, collapsed right lower lobe, and then these bigger guys are going into the right upper lobe. So it really is dramatic vascular attenuation into that.
But I would think that if this were congenital and had been there forever, then the vessels to the normal parts of the lung would never have grown normally, and they would be small. They would reflect, basically the neonatal size. They would never have grown. And the fact that you've got respectable vessels suggests to me that this is really acquired.
Interesting. Yeah, I've just never seen. Yeah, I was totally confused. I didn't know. And you can see the airways plug up immediately. The medial and segmental bronchi just almost go away. You can't even see them, and you don't see any airways distally. Presumably from the emphysema, I was confused. So
she seems like someone that might benefit from an endobronchial valve. Is that what they're thinking about for that right middle lobe?
Yeah, she has, homelessness, meth use. Yeah, she comes in every once in a while with shortness of breath and gets a CT scan. Anyways, I'm glad I'm not the only one who's
right
confused about things.
Yeah,
and
I think if she hadn't had the central lobular emphysema everywhere else, then
yes,
I think I'd be more likely to call
absolutely
it developmental. But I think, as David said, makes you wonder if it's just smoking related.
Yeah, and that's what I was wondering, because exactly, she had really bad emphysema everywhere else, but it was so dramatically worse in that one lobe, and I've never seen it in adults, although you guys have, and I'm still torn, but I'm glad to know that.
Let's call it vanishing lung, and she's the wrong sex, she's the right age, but the wrong sex, and it's the wrong location. But people aren't perfect.
Vanishing lung is usually associated with sarcoid
or smoking. It's usually described in young men who smoke, and it's more upper lobe. They get these large bullae.
Yeah.
Oh! Isn't there a vanishing lung you can get in sarcoid too, or is that
that's shrinking lung you can get with
shrinking lung? Sorry.
Yeah. You could call it right middle lobe syndrome, except that's already taken.
Right.
It's the exact opposite.
This is a 45-year-old that came in with bladder cancer, relatively low-grade bladder cancer, and had this anterior mediastinal mass. It had kind of multiple surrounding lymph nodes. It was kind of going into the chest wall a little bit, and I really thought that this would be, and no other disease, nowhere else in the whole body. So just a bladder cancer that wasn't that super aggressive, T2, and this thing, and I really thought, he was 45, could this be germ cell tumor? Could it be lymphoma? It's not typical for thymoma given the lymph nodes around it, but it's possible. But anyways, this was biopsy, and it was metastatic urothelial cancer.
Jeez.
And that was it. Just literally no other site of disease except sitting here in the anterior mediastinum. So just, because they showed it to me, I was like, oh, it's definitely not Mets. That's definitely a secondary tumor. But of course, whenever you say definitely, you're going to be wrong. Definitely. So, but anyways, those are my cases.
Oh, thank you. All right. Who'd like to go next?
I could show a couple.
All right.
So this is a fresh case. this person just came to Harborview. Has a history of a couple of months of fever, weight loss, night sweats, and has this abnormal chest radiograph. We can all see the radiograph, correct?
Yes.
Okay. And so it appears here on CT as if we have this lung disease worse in the upper parts, but trailing down toward the bases, probably cavitation on the left, probably cavitation in the right apex as well, and then a substantial pleural abnormality here. And on CT, again, we have cavitation, particularly on the left. And then we have this sort of acinar rosette pattern of lung disease. This doesn't fit tree in bud. Everybody's thinking about TB, given the history on this person. Trails off toward the bases, but this sort of, acinar filling pattern all over the place. And then it appears that the left pearl process is very mature. It's probably left over from something long ago. This person had history of travel to Indonesia 3 years ago with his sister. Wasn't in remote villages and things like that. People considered a variety of infections, and PCR came back late yesterday for tuberculosis. So this is a case of florid tuberculosis here, and sort of an atypical filling pattern here of the lower parts of the lung. So I've not been aware of this pattern before of, it really looks like acinar rosettes here every place. So I don't know whether this is familiar to you guys, but it wasn't familiar to me. And the fact that he's this pleural process is mature and old raises the question, did he have remote TB? But there wasn't any history of that as a cause of some pleural thickening here with some thickening of extrapleural fat. This is very mature looking, and it's not, I don't think it's part of the acute process. So TB at least TB at this point, and so far no other organisms identified, but truly florid disease.
Interesting, that rosette pattern you see in like that, the metastatic pulmonary calcification with renal failure, not the upper lobe and all the cavitary stuff, but when you see bad cases of metastatic pulmonary calcification from renal failure, it also has that rosette-ish pattern. It's but that's
and with pulmonary hemorrhage too likes to have that.
Yeah.
That sometimes you see this little clear halo around the edge of the lobule.
I think that this may be a matter of the extent of disease. I think if earlier one had imaged that, in every one of those areas of rosettes, the bronchioles would have been opacified. But as the materials left the bronchioles into the peribronchiolar alveoli, those portions of the pulmonary lobule became more opacified. So you're left with this pattern. Because I think in between some of the larger areas, I can see bronchioles.
Right. And a little bit of tree and
I think this is just a matter of how florid the abnormality is.
Yeah. Just
so tree and bud going on to flower completely.
Yeah. Impressive.
Right. Yeah.
Okay. Let's see, who else do I have here? This is a woman with GPA and with sinus disease here on this pretty extensive sinus disease here, and in terms of her chest abnormalities here, her lungs are pretty good. Maybe a little scarring here in this left base, but the interesting abnormality is the airway here, with airway involvement probably by her GPA, with this thickening around the lower trachea and then the proximal bronchi on both sides, and more narrowing here on the left and the right with this thick wall. Here's the thick wall of the right upper lobe bronchus, and then bronchus intermedius is also thickened. So then things open up past that. So airway involvement here of GPA. Let's see what that looks like on coronal. Maybe we can bring it out here. I think we can see the narrowing, particularly here on the left, and the thickening of the wall. So GPA in 2 locations. I don't know whether she had renal disease as well. I'll have to look that up.
Do you know if her C-ANCA or anti-proteinase 3 was positive?
I will have to do the investigation. I just
Yeah.
kept.
The reason I ask is sometimes when they just have airway involvement or not really like cavitary or nodular lung disease, sometimes their antibodies aren't positive or not very high.
Got it. Okay.
Very nice example of airway disease. Yep.
Okay, now this person has a lacy pattern of small nodules here, both sides, mid-lung predominant, tapering off to the bases, and then had this larger lesion here in the left apex, left upper lobe, sitting along the fissure with cavitation. This was resected, and they recovered necrotizing granulomas from it. And this is all in the setting of sarcoidosis. So here's sarcoid with a necrotizing component here. And I think in some of our recent discussions, I think, was it you, Jeff, who brought up the point that necrotizing granulomas are not all that uncommon in sarcoidosis. Most of them are non-caseating, but you can have necrotizing granulomas as part of it.
Right.
Was it you?
Yeah, that's what our pathologist said and showed an example.
Right. So here's another example where there was a necrotizing granulomatous process as part of sarcoidosis. And once that was resected, things have stayed pretty much stable for many years. So up until this year, we have the same pattern of small nodules, not floored, not going anywhere. So that's one case of sarcoid. And then here's another case of sarcoid. We show some nice evolution. This is outside radiographs on this person from 2011 with lots of bulky stuff here, mid-lungs again, and around the hyla, maybe some pleural effusion or thickening, unusual in sarcoid. And then here is more current imaging now on this person. And there's been a lot of scarring. And now we have this central scarring pattern with very nice, probably PMF pattern here. I'll show you CT in a minute. And then lots of calcified lymph nodes with some eggshell calcification and lots of pleural thickening here. And here's what current CT looks like. This person, lots of distortion, these big perihilar blobs of tissue here, lots of calcium. So stage 4 sarcoid with a kind of a PMF pattern, with the central scarring. And then we can bring out the calcification along the outer edge of many of these lymph nodes. Some of them are in the center for the calcium, but some of them are nicely peripheral, a la eggshell. And pleural thickening here, not pleural effusion. So 2 cases of sarcoid. So I like the progression here from the softer lung abnormalities crowding the hyla here to this scarring pattern here and elevation of the vessels off the hyla, progressive scarring, and tethering here of the lung bases, attempts to hit juxtaphrenic peaks and so forth. And the pleural involvement, I'm attributing this to the same process. You don't see that much pleural involvement in sarcoid, but this one I think has a pleural thickening that's legitimately probably part of the same process, probably part of sarcoid.
Yeah, very impressive.
Okay, those are the cases I wanted to show.
Okay, Jeff just texted. I think he's on the phone. Howard, I'm going to take control and show 2 cases and then give it to you if that's okay.
Sure. No rush, take your time.
Okay, do you guys see a CT?
Mm-hmm.
All right, well, this is Howard and David. This is for both of you. This came in on Tuesday, and I think I've got all of the information except path confirmation, but I know what the first question is going to be, and I think I have an answer for it when we get to it. So my first-year resident picked up this case, and as we were reading it out, he said the history is splenomegaly, evaluate for lymphoma. Patient had some constitutional symptoms and apparently splenomegaly. And you can see, I got excited very quickly when I saw this, as you see this soft tissue that's infiltrating in the pericardial space. It insinuates into the interatrial septum. A little bit of soft tissue probably encasing the right coronary artery as well. You can see it along the posterior wall of the right atrium. So, by this point, I was like, well, this would be a very good look for lymphoma, and just talking about the difference between this and lipomatous hypertrophy of the interatrial septum. And then I said, let's go look at the spleen and see what's going on. And the spleen looked okay. And then I saw this, and all of a sudden, as you would imagine, my tune instantly changed because now we've got this symmetric infiltrative soft tissue surrounding the kidneys. And so now we're thinking Erdheim-Chester, and really, not much of a differential, I think, at this point when you combine those two, as we've seen cases where it involves the heart, the aorta as well. So
Travis, was there a halo around the descending aorta there in the lower chest?
there's not. I think this is mostly just atherosclerotic disease. I think in the abdominal aorta, there's a little bit of lines of soft tissue back here. Certainly in the abdominal aorta, there's some retroperitoneal stuff you can see. And I think to distinguish it from retroperitoneal fibrosis, there wasn't a lot of deviation of the ureters like you would typically see. But now I know the next question would come from you guys, as normally does during this discussion, is what do the long bones look like? How you get the sclerosis. The proximal femurs don't look that bad, but we said this was probably going to be. I thought this was Erdheim-Chester. So yesterday they did a skeletal survey, and I think the proximal tibia on both sides. One of our bone radiologists said yes, there's a little bit of subtle sclerosis here, which is typical of Erdheim-Chester as well. It doesn't have to be the proximal femurs. You can have a lot of stuff around the knees. And they subsequently did this morning an MR, and you can see, let me get these T1, you can see that there's infiltration of the normal marrow fat with the lower signal intensity stuff. So that all goes towards Erdheim-Chester as the diagnosis here. Wow. But what's interesting too is this patient had back, as you see, last October at an outside hospital, had a brain MR because they were having some vision changes and other stuff. And you can see that there's this enhancement within the pons, probably a little bit of the cerebellum here. And also there was this infiltrating retroorbital soft tissue surrounding the optic nerves. And so when I dug into the literature, it turns out all of these are findings typical of Erdheim-Chester.
Wow.
We find the right, so this is an article that was written by some of my friends at Mallinckrodt. This was the case that came into Mallinckrodt with this pericardial or the cardiac involvement. It's very similar distribution. You can see more profound involvement of the kidneys, and then more profound involvement of the proximal femurs here. But this
Did you not see
article,
did you not see the case I showed last year in MR? That beautiful.
Yeah, it's like the same, right? It's so because it doesn't always involve cardiac stuff.
Yeah.
But we've had a few. This was the AJNR article, and there's junk in the around the knees, and then this is the image. So there's all this stuff just infiltrating the retroorbital soft tissue.
Jeez.
So, did your case, Seth? Did it have orbital involvement or neuro involvement? Do you know of?
Oh, I don't look at that stuff. Sorry. I see. I got to the superior edge of the kidneys. I say, okay, Erdheim-Chester. There we go.
But I came prepared with all the bone stuff too, because I knew that was going to be David's first question.
So,
the lungs have any pleural thickening?
No, the lungs didn't really have anything. Actually, I did. That reminds me. There was one other question I had for you. Was the lungs look fine, but I'm curious what you think of the aortic arch. I think a lot of this is just that bad atherosclerotic disease, and there was some question of whether or not there could be a vasculitis. I was like, I think it's just a lot of this just ulcerated plaque. I don't know about
How old is he? Most of these times, the guy's 70s.
He's 55.
Really?
So yeah.
He's not
So
healthy.
that's the only
I'd be
thing you wonder
suspicious
about how
there's
ratty
really
his aorta is.
55. Most of
Yeah.
it looks like atherosclerosis, but that's a lot for a 55-year-old.
Yeah. Sorry, David, you said something?
I think this aorta is probably involved. Just
stuff.
given his age and given the abdominal findings, that's a lot of wall thickening, and there's not that much calcium.
Yeah. The intimal stuff looks more like atherosclerosis, but you're right. That's the adventitia looks like it may be enhancing.
Right.
So
the business about the bone involvement here is people are really have gotten the wrong idea, and that's because the largest series of cases until about 5 years ago or 10 years ago was derived from a bone clinic in France. And so when they published their you know, there are 60 cases or something like that. These were cases who had come because they had bone pain. And so in that population, they're like 2/3 or 80% of the people had bone findings, but that's because of the patient selection. If you look at other cases that don't come from bone clinics, you get a much lower percentage of people that have the tibial and fibular and femoral findings. So the notion that you have to have that, or that it's true in 85 or 90% of people is just wrong. It's based on the misleading statistics from one of the early.
Right. I think I would argue, though, that when you have it like in this, it certainly helps solidify the diagnosis.
Absolutely, when you've got it, but you shouldn't require it.
Right. So, okay, then one other, so that was Tuesday. This was also, let me go to the right one. This also was referred to us on Tuesday, and this is a question. I think we have an answer, but I just want to see if you guys agree. So this is a 44-year-old man who's had recurrent respiratory infections and was sent to our ILD clinic with what was presumptively diagnosed as a cystic lung disease. But as you can see with these, that a lot of this is cystic bronchiectasis, and it's very focal in areas. You know, like I think this is a good example right here where you can actually see this cyst communicating with an airway. So it's actually cystic bronchiectasis rather than cyst. He actually had a surgical lung biopsy done elsewhere where they got a report of what they thought was an NSIP type pattern. But I think that this is, I think this is cystic bronchiectasis. And Brett Elliker and I were talking about this, that to us, this looks like Williams-Campbell syndrome. And I'm wondering if you guys agree or disagree, just given the distribution, how it's more focal cystic bronchiectasis and scattered out in the periphery of the lungs.
I think I've seen in a bunch of places, maybe higher up, that the more distal generations of airways that are not necessarily dilated, but are abnormal. And in a couple places, I think I see material in the lumens of bronchioles. So
yeah,
I think
like out
airways
like out here.
are also involved. So I think it's a more extensive bronchial and bronchiolar process, which, like, I'm beginning to see tree and bud quite a bit, I think, in some areas, like there.
That can just be obstruction from the more proximal disease. I don't, this is one of those ones that, I still, I've never had a confirmed case of it, and I know it's hard to make the diagnosis even on path.
I with these cases of Monier-Coons or William Campbell, where it's supposed to involve a certain distribution, I find that with age and repeated infection, that the more distal, the airways distal to where the abnormality should really stop, get involved, because the more proximal airways get infected, as then you get subsequent infection of the more distal airways, and then they become abnormal and dilated. So I find that the first to fifth order in tracheobronchomegaly and the fourth to sixth in Williams-Campbell, those kind of get blurred as patients get older and the infections become repeated. So I don't know. I always struggle with.
The other thing is that there's no consistency in the reported cases of Williams-Campbell. It's really just a hodgepodge, and I think you have to put that diagnosis in quotation marks. But
I don't know what it means.
Can you give us a coronal on this one? It would
sure.
Be nice.
Yeah. And so this one, the patient's going to undergo a full bronchiectasis workup. They'll even alpha-1, antitrypsin, like even though that's usually more lower lobe, as David, I think, has shown cases of pure bronchiectasis in that. But I think that's kind of the working diagnosis at this point. So
I would go, even though there's a lot of bronchiectasis because of the small airways as well, I think it'd be important to exclude something like a weird case of chronic atypical mycobacterial infection, even though this would be a bit unusual because there's so much abnormality in those smaller airways. I think they should exclude a chronic infection.
Yeah, well, and they'll do immunodeficiency workup and stuff. I mean, it's pretty diffuse in terms of its craniocaudal distribution. I think it's interesting too. There's several little tracheal diverticula But yeah, I kind of agree with Seth though, that I think that you just, when you damage the more proximal airways, you're going to end up with more distal infections. So he could be colonized now or just having repeated infections from the inability to clear more proximally.
Definitely infected. I mean, it's just like every CF patient, every CF patient's got 50 strains of whatever growing in their airways. You expect the same thing here.
Right. This is just his most recent pneumonia up here in the right upper lobe. So
a lot of these cysts are not clearly connected to airway for me. I mean, a lot of them seem to be just sitting out there. If there's an airway going to them, it's pretty small, and then this sudden dilation. This is very strange. I don't think this fits any described pattern that I've ever seen before.
Okay. It's not a slam dunk.
I wonder if these are maybe some of these are pneumatoceles that have arisen in a peribronchial location from a remote staph infection. The pneumatoceles in that situation usually come from little diverticula off the airway, so they're adjacent to airways. And the fact that these things are so sudden, we don't have airway dilation leading to them, suggests to me these could be that sort of condition of peribronchial pneumatoceles from remote staph. I'm not sure this is just bronchiectasis.
Okay.
Travis, in that particular image, if you change the window width, because there seem to be maybe some bronchi filled with stuff near the cystic spaces in the left lower lung.
Yeah.
There's no high attenuation mucus to suggest, chronicity.
No. In fact, that reminds me, because there was the one case at Emory that had actually in the past had been written up as a case of Williams-Campbell syndrome, and then the guy came back. It turned out he had ABPA all along, causing the bronchiectasis because he had high attenuation mucus and stuff. So I think to David's point about the heterogeneity of how these are reported or diagnosed definitely is true. So they're going to review the path, and I don't even know if is there a specific gene that's involved with Williams-Campbell that there are genetic tests for now? I don't even know.
Oh, there aren't any specific tests.
Okay, well, I'll give it to Howard for the last 10 minutes here.
Okay. All right. I'm going to show this case backwards, and you'll see what I mean by that. So here we go to a recent exam. And the finding I'm going to show you is nothing to do with its clinical presentation. In fact, I can't quite remember what it is. But if we were to describe these opacities that we see down here, we would all probably use terms like subsegmental sized opacity times 1 times 2 in the right lower lobe, consistent with scarring, and just go on, and that's perfectly fine. So indeed, that's what he has, just 2 foci of scarring. Each one is just a portion of a pulmonary lobule, and it's very small. Each one is just irregularly shaped. And of course, if we go back in time, we see the genesis of that, which is an episode of pulmonary embolism. So the time here is years, at which time there he had these peripheral opacities, very typical of foci of pulmonary hemorrhage, a little bit of pleural fluid, pulmonary embolism. And of course, you can't predict or know to what extent you're going to develop an infarct in there. When we see this disordered aeration, we usually like to think there's probably an area that's going to become eventually a small collagenized infarct, but you don't really know. But this is what this person ended up with. And people talk about, in the context of PE, they talk about wedge-shaped opacities that may develop. And of course, these are not really wedge-shaped. They're just, basically, they're irregular. And I always like to remind people that if you go to Hampton and Castleman's article back to 1940, and you look at the shapes of the infarcts that they took out of the lungs, they can be all kinds of shapes, including just small, irregularly shaped things like that. So that's the reminder that you don't really get necessarily wedge-shaped infarcts all the time. They can be big, small, and variably shaped. So this goes along nicely with this one picture in Hampton and Castleman's article. of little infarcts, right like that. All right. This is just a nice example. I shared this the other day with some folks of a trauma patient in whom a trauma CT was done. And an incidental finding is the presence of air in pulmonary artery segments. So obviously, inadvertently, air was injected along with the contrast medium. And as I scroll through it, you'll see areas like this that at a first glance look like a bronchus, but that's actually a vessel that contains air. Travis showed this before, and we talked about the notion of a double barrel sign of air embolism in pulmonary artery segments. And let me show you, this one is quite cute because I think we can see sort of an airlock phenomenon. As you might imagine, if the air in the pulmonary artery here impedes the flow of contrast medium, it's not surprising that we'll get a bit of water, a bit of contrast medium, almost like a fluid level of the contrast, and some blood, and then the air producing a bit of an airlock phenomenon in that location. So, of course, we're going to see the air in the more anterior vessels, in the upper lobes, but even in the lower lobes, like right there, of air in pulmonary artery segments. So it's always a little embarrassing to see that much air. It's pretty uncommon, but no harm will be done by that air. All right.
Howard, on that one, on that case, did you think that there was some air mixed in with the contrast in the pulmonary veins returning from those?
Oh, I did not perceive that. Let's have a look. I think orbits in the arteries. You're asking about whether there's any
in those proximal pulmonary veins?
Phenomenon in veins coming back. No, I did not perceive that. Going all the way through the capillaries to veins, no. That would be pretty unusual, huh?
I just wonder if some of the stuff got through the capillaries and was coming back.
Don't think so, no.
Okay.
You can see all the places we see it are all in arteries in the different places. Yeah. Okay. This is incidental Aloma. Let me see if I got the right case. Well, I've got two actually that are really incidental Alomas. I can start with this one. There's a super nice case of extensive calcification of mitral valve annulus. When you do the bone window, you can appreciate how this, when you take this material out, if you were to take this material out, that it would look like caseous material. So you have some calcification in the periphery, and then the internal portion would look like that white, milky, caseous material. So caseous calcification or caseous necrosis or tumefactive necrosis or calcification of mitral valve annulus. Pretty florid as an incidental finding, but a really nice attenuation difference between the calcium in the periphery, and I don't know how much calcium is in there, but that would be the so-called caseous material that would come out if you were to take it out. So usually describes something like this: upon perforation of the mass, toothpaste-like milky caseous material is expressed. This is not this patient, just how it's typically described. A calcified envelope surrounds the caseous material. And when you look at this, it makes perfect sense why it looks the way that it does on CT.
Howard, I had a case of this, 10 years ago or something like that, and looked up the literature, and it turns out that sometimes these chunks of calcium associated with this mitral annulus calcification can break off and embolize and end up in peripheral vessels. I don't know whether you guys have ever seen a case. I thought we had a case where that might have been the case.
No, I don't know. And just embolized, huh?
Mm-hmm.
Yeah, I'm sure that, no, I've never encountered that. I mean, people with this sometimes do have TIAs and stroke, and sometimes the stroke is blamed on this, like little fragments coming off.
Mm-hmm.
But I've never seen or heard of a case where there's a big macroscopic glob going, say, down to the extremity and blocking an artery in the extremity.
Yeah.
Wow, no, I've not seen that. Last one will be a nice quick one too. So this one is another incidental loma. And this one is a interatrial septal aneurysm. So you can see the nice bulge from left atrium to right atrium. Here is a coronal depiction of it. And I think it's usually said that when you see that and you kind of measure it, some people use a measurement. So if you were going to measure it, you might say, well, if this degree of bulging is more than 1.5 centimeters or so, this one's like 2 in that dimension. That's pretty typical for a septal aneurysm. So this one is of that size. Again, as an incidental finding. A nice example of that. Unless you guys think I'm wrong and it's something else.
No, I agree.
Otherwise,
I think that's, yeah, I don't know, Seth, have you ever seen anybody actually intervene on one of these? I don't know, Seth may be gone.
Sorry, Seth stepped out, sorry.
Yeah, I've never seen one of these actually,
no, I don't think
require
so.
any sort of intervention.
Usually if
They
there's a
have been
multiple
reported
trace
to be
question.
associated with, yeah, they've been reported to have association with thrombus or PFO, but I think PFOs are so common, you wonder if it's just incidentally discovered with them.
Yeah, I saw a multiple choice question online when I was looking for examples of this from the cardiothoracic literature, I think, and it gave a couple of options. And one of the options was leave alone, and that was the correct answer.
Okay, good.
They don't do anything else about him, just leave him alone. As an incidental finding, an older person, of course, yeah.
Okay.
Alrighty, there we go.
It looks like Jeff had to step away, so I guess we will conclude.
Thanks, everyone.
See everybody next week. Thanks.
Alrighty,
Bye-bye.
thanks everyone. Bye.